Hey, it's Steph, and welcome to the Straight Up with Steph podcast, where we have real discussions around health and life and just trying to be better at both. Hello, and welcome back to another episode of Straight Up with Steph. I'm Steph, your host, and today we're talking about something that I get a lot of questions about, which is patient positioning. This is huge for us with our posture and our ergonomics because our patient's position really dictates our position. If we want to have good posture and good ergonomics and no chicken wing or leaning or twisting, we really have to make sure our patient is positioned correctly. If you think about it, wherever we place anything, our body is going to have to acclimate to that. So if you think of putting a vase way up high on a shelf, we're going to have to reach really high for that. That's our body adapting to wherever we are placing the vase. Or if we have something in a really low cabinet, we're going to have to be hunching over or getting down on our hands and knees to get into that cabinet. If you think of your laptop or your cell phone, I see this all the time with laptops being placed too low. If the laptop is just being placed on a counter or a desk with nothing to raise it up, the person is hunching over working on their laptop. If our cell phone is held in our lap or down low in front of our abdomen and we're texting or watching videos or whatever, we're literally hunching over that cell phone. So wherever we place whatever it is that we're working on, it dictates our posture, and the same with our patients. By the way, if you want more tips on neutral posture, like what that is and how to get it, whether you're in the operatory or with your cell phone or laptop or whatever, I do have an episode on posture, which I'll link down below. Like I said, our patient's position dictates ours. If our patient is positioned too high, what happens? We can't be in comfortable, healthy, neutral posture. We're usually out in chicken wing, right? Or our shoulders are raised up to our ears, or we're twisting or hunching or trying to get upside down in order to see them. All of it's not good. Also, whatever kind of loupes you're using will dictate your posture too. Let's say your patient is positioned too high. Whether you use ergonomic loupes, regular loupes, or no loupes at all, your position is still going to be awkward. A lot of times people get ergonomic loupes and they think that that's going to solve all of their issues, and it's not. We still have to make sure our patient is positioned correctly. So no matter what you're using, as far as loupes or no loupes, if your patient isn't leaned back far enough, you're still going to have awkward posture. I'm going to demonstrate what I mean using ergonomic loupes and regular loupes a little bit later. So if you're listening to this, you might want to check out the video on YouTube, at least for that part, so you can see what I'm talking about. I've done a lot of assessments on dentists, dental assistants, and hygienists over the past few years, and many, many times the patient is positioned too high, either by just a couple inches or a lot of inches, but either way, it's not good. Even a couple inches is too much because that means that those are inches we're going to have to make up for. Even if it's an inch or two, that means our shoulders are raised or our arms are out to our sides or we can't get close enough to the patient or whatever it is. So mastering patient positioning is huge. I get asked often, what's the most important thing for someone to learn as far as ergonomics? It's hard for me to answer that question because we're all different and we all struggle with different things. But if I had to pick, I would say operator positioning as far as our posture, neutral posture, and clock positions, and our patient positioning. If we can get those two mastered, I think we'll be in pretty good shape. Correct patient positioning is not easy. It's tough. Many of us in dentistry are empathetic and we're caretakers, and we know that our patients, for the most part, coming in to see us isn't their favorite thing. I mean, we do have those patients that really do like coming to see us, but most of the time, it's not their favorite place. So we don't want to ask any more of them as far as tipping them further back than they're comfortable or moving their head for us or whatever, because we want them to be comfortable. I remember when I first got out of school and my first job as a hygienist, I would try to get my patient in the correct position. And then some of them would complain. They would say they can't lean back that far, or I was tipping them upside down, or they're uncomfortable. And I was new and I wanted them to like me. I wanted them to be comfortable. I didn't want them to be anxious. And so I would basically do whatever they wanted. This became my habit over time to where I wouldn't even try to get my patient in the right position anymore because I wanted them to be comfortable. It's great for them as far as them not tipping back any further than they want or not having to move their head around for me. But what did that mean for me? My body was the thing that suffered because of that, because I was doing all of these acrobatics in order to try to see them. So it's definitely not worth it. Just imagine if you're a woman Going into your annual pelvic exam and telling the doctor you can't get up onto the table, you can't lean back, you can't put your legs up into the stirrups, and you can't spread your legs. That would make it impossible for them to do their job. If you're a man listening to this, just know as women, when we go in for our annual pelvic exams, we have to get in a very uncomfortable, awkward, vulnerable position. I won't go any further into detail as far as what else happens after that. But just know if we don't get into that position, we're not going to get a thorough, good screening for cancer. When I go get these done, yeah, it's uncomfortable and awkward and I don't like it, but I'm going to do what I need to do so that they can do their job and check me for cancer. It's the same thing when patients come in to see us. We have to get them in the right position for us to do our job. We're providing a service for our patients, a really important service, and we need to get them in the right position. Not just for us to have good posture and be able to work comfortably and not hurt ourselves, but for us to provide the best care that we can. I think many of us have had at least once or twice a patient who cannot lean back in the chair. We know that that's not our best work. We're doing what we can. We're doing the best we can. It's not our best work though, which doesn't make us feel good as far as clinicians, and really it's not the best thing for the patient either. I understand that we do have some patients that cannot lean back in the chair because of medical reasons or vertigo or whatever, like I get it, but many of our patients can be leaned back all the way in the chair. It all starts with us as far as our mentality and how we handle things in the operatory. We can still be sympathetic and caring with our patients, but we can also be firm as far as what we need from them. If you struggle with patient management when it comes to positioning, I do have a chapter on that a little bit later. If we want to have good posture with no chicken wing, not feeling like crap at the end of the day, not hunching and leaning and twisting and all of that, it all starts with our patient positioning. I want to let you know I have an on-demand video-based patient positioning course that goes over step-by-step how to position your patient. This podcast episode is great. It's a quick overview on patient positioning, but a lot of the concepts I'm talking about are really better learned visually, and that's what this course does. When I talk about using cushions and how to position the cushion and where you want the occlusal planes for the maxillary and mandibular arch, it's much better learned by video. The course also has some bonus content as far as a whole micro break playlist. If you follow me on social media, you know I talk about micro breaks a lot, and I have full videos of all of the micro breaks that I recommend. There's also a really good mirror technique. Some of us forget about our non-dominant hand, but when I'm doing assessments, I'm not going to say 100% of the time, but pretty close. Most clinicians are doing the chicken wing with their non-dominant hand. Our non-dominant hand and arm is even more at risk for getting injured than our dominant one because it's like literally hanging out here in space. We're retracting a really strong cheek or a strong tongue. We're out in chicken wing and we're not giving this arm a break. This mirror technique that I teach you eliminates the chicken wing, and you will notice a huge difference with your non-dominant arm. That course is linked down below for you. Before we talk about patient positioning, I want to give you a good benchmark that you can use when you're in the operatory. When you're sitting or standing in neutral posture, you want to be up nice and tall. Again, if you need guidance on neutral posture, please check out that posture episode. When you're in neutral posture, either sitting or standing, you're up nice and tall. You've got your arms close to your sides with the elbows bent at about 90 degrees. This is ideal posture. No, we can't be in it 100% of the time, but we can for a lot of the time. When you have your elbows bent at 90 degrees and your forearms parallel to the floor, I want you to look down at your elbow. That is going to be your guide. When you recline your patient, you want their mouth to be parallel with the level of your elbow. So that's a great benchmark you can use in the operatory. When you have your patient's mouth down that low, it means your arms are nice and relaxed, close to your sides. Your shoulders aren't raised up to your ears. You're not out here in chicken wing. You're not like upside down doing all these crazy things. You're nice and neutral. Your elbow can also be a good guide for your instruments. I know not all operatories have an adjustable surface for the instruments, but if you do have like a bracket table that you can go up and down with, you want that bracket table to be at the level of your elbow also. I've done assessments where people have elbow pain or even wrist pain, and it's all because they're reaching up to get instruments from their bracket table or reaching up to grab their air water, and it's literally just a few inches too high. So make sure your instrument or bracket table is down at the level of your elbows too. When we recline our patients for the maxillary arch, we want their body parallel to the floor in a supine position. So you recline the chair all the way down, have their body parallel to the floor, and then you want to have them scoot all the way to the end of the chair. This is whether you're working for the upper or lower arch, but you want them to scoot all the way to the top of the chair. You want the top of their head in line with the top of the headrest. A lot of dental chairs have adjustable headrests, which can be our ergonomic best friend, especially when it comes to positioning, but we have to know how to use it, and the head has to actually be on that headrest. If it's like halfway on the headrest, it's not really going to do much for us. So have them scoot all the way to the top. It's all about where the occlusal plane is placed. So I'm going to use this typodont here. If you're not watching this on YouTube, I do recommend that you check at least this section out so you can see what I'm doing. It's just hard to visualize this when you're just listening to it. When we recline the patient back, we want the maxillary teeth to be in a certain place. So I'm just going to open this a little bit. Imagine a vertical line going through your patient's mouth from the side, from the profile view. I'm just going to use this mirror as an example. So this is our vertical line. You want the maxillary teeth to be behind that vertical line. You don't want it in front here, okay? You want it back here, honestly, as much as possible. If I'm sitting at 12 o'clock, which is a clock position I recommend us trying to prioritize, we can't always be at 12 o'clock, but a lot of times we can. So we want those maxillary teeth to be pointed back towards us. And when they're behind that vertical line, that means it's a nice, easy reach for us to work on those upper teeth because the teeth are kind of coming to us in a way. If those teeth are in front of that vertical line, that means we're going to be reaching forward or hunching forward in order to see the teeth, which isn't good. I'm trying to explain this as best I can with the typodont here, but that patient positioning course, I'm working on a live patient, and it's just a lot easier to understand that. To get the patient's head in that position, if you have one of those adjustable headrests, you want to decline the headrest a little bit so that it forces the chin to go up towards the ceiling. I also use these cushions. These are patient positioning cushions. This isn't like a couch cushion that you bring from home or a dog bone cushion that puts the patient's head in an awkward place. These really help support the cervical spine, but it also gets the head in the right position. And how I position the cushion depends on which arch I'm working on. If I'm working on the upper arch, I want this big fat end here to be behind the patient's head because it kind of forces the chin to go up towards the ceiling. If you've ever reclined your patient down and then asked them to tip their chin up, they'll do it, but sometimes they drift back down, right? And then you have to ask them to tip it up again, and then they start drifting back down. These cushions really help lock them in place. I also have these cushions linked down below. I'll tell you how I use this for the lower arch in just a second, but these really help. If we support our patient's cervical spine, and what's nice with these cushions is you can attach it onto the patient chair so they can feel that support right when they sit down, when you're taking blood pressure or doing your pre-rinse or whatever. They feel that support. When you start to tip them back, they feel like their head and their neck is supported, and they will let you tip them much further back than you thought possible because you're using a cushion like this. It does really help. Don't be afraid to ask your patient to tip their chin up towards the ceiling. When I'm seeing patients, they are very active in what I need for them. I'm having them tip their chin up or down, moving their head side to side because I want to do a good job. And to do that, I need to be able to see. So they need to move for me. So don't be afraid to ask your patient to move for you. Once you've got the occlusal plane where you need it to be with the chin up and those teeth behind the vertical line, then you need to look at the level, vertical height of the patient chair. Is their mouth at your elbow level? If it's too high, you need to vertically lower the patient chair or raise it, or just depending, so that their mouth is at the level of your elbow. That's a great position for the maxillary arch. When we talk about positioning for the mandibular arch, it's very different from the upper. And I used to practice like this too, and I see this with clinicians when I'm doing assessments. The patient is reclined back to whatever position, and they don't move for the whole appointment. The headrest doesn't move. They don't move their head for the clinician. They don't move their head side to side, like nothing moves, which is great for the patient. But then the clinician is forced to do all of these crazy things in order to see them. That's not the best way to go. We need to start getting very deliberate whether we're working on the upper arch or the lower arch. Positioning for the lower arch is different. So instead of having the patient parallel to the floor, we're actually going to raise the back of the patient chair up about 20 or 30 degrees. So they're in what's called a semi-supine position. We need the mandibular plane of occlusion in a completely different spot than it was in for the maxillary position. We need the chin tipped more down towards the chest. So for the upper arch, the chin is tipped way high. For the lower arch, we need it tipped down a little bit more. To get that, you're going to adjust that headrest to where it's not declined anymore. It's going to be more flush in line with the back of the patient chair. When you do this, it kind of forces the chin, the patient's head, to tip down towards their chest. These cushions also, I will flip it around so that this fat part is not at the neck, it's more on the patient's head, the base of the skull, which forces the chin to go down towards the chest. It's still supporting their neck. They're still comfortable, but it's kind of getting the chin to nod down towards the chest. And don't be afraid to ask your patient, Mr. So-and-so, please nod your chin towards your chest. That's going to be a much better position for you. For occlusal plane guidance, we're still going to use the maxillary teeth as our guide. So we've got the vertical line here. We've got the maxillary teeth behind that vertical line for the upper arch, but we need this in a different place for the lower. We actually need the maxillary teeth either close to or in front of that vertical line because we need the mandibular arch to be more down, not like parallel with the floor, but just more close to parallel than it was for the upper arch. So we need those maxillary teeth to be close to or in front of our imaginary vertical line. That's when you know you're in a good position for the lower arch. For the lower, it's a little tricky because we've raised the back of the patient chair, right? So their mouth is no longer at the level of our elbow. We need to vertically lower the patient chair so that their mouth is at the level of our elbow. Now, there are some chairs that legit will not go down far enough. Or if the clinician, especially if the clinician's more on the petite side, it just doesn't go down far enough. And then they're forced to be out here in chicken wing. So don't do that. There are some options. You can leave the patient in full supine and just adjust the headrest, flip your cushion around, and direct your patient to nod their chin towards their chest. You don't have to put them in that semi-supine position if your chair doesn't allow it. You can also get a saddle stool. A saddle stool raises you up higher so you have more play between like yourself and the patient so you're not so scrunched up. Or you can stand. It's not uncommon for me to stand for the lower arch. I do recommend standing, alternating, sitting and standing when you're seeing patients. And this is really comfortable when you are working on the lower arch. So very different positions, whether we're talking about the upper or lower arch, and we really have to start being deliberate with how we position our patients. Now I want to talk about some difficult or more challenging situations. We have pedo patients. Their little bodies just don't fit into these huge chairs that we have, right? That's a lot of real estate for them to be moving around. But the positioning rules are the same, whether you're a tiny human or a regular size human. When you tip them back, you want them to scoot all the way to the top of the chair. I see this a lot when I'm working with clinicians who work in pediatrics, is the patient's head is like somewhere down on the back of the patient chair, not even on the headrest, just like on the chair back somewhere. And they're really having to like reach forward in order to see them. When you tip the patient back or the chair back, you want them to scoot all the way to the top. And this might look kind of weird because the entire body of that pedo patient is on the patient backrest, but that's fine. We need their head all the way on that headrest because when we start moving it, we want to actually be moving their head. Pedo patients typically still want to please us. They see us as an authority figure still most of the time. So we can ask them to scoot all the way back. And they don't have issues with vertigo or mobility or whatever, so they can get all the way back on the chair. We need to do that. What we're trying to do is eliminate any open space on the headrest. What I mean by that is when, let's say you're sitting at 12 o'clock and you look down at the headrest at your patient, you don't want to see any visible headrest. We want their entire head all the way up on that headrest. Because if there's even an inch or two of open space of headrest, it doesn't seem like a lot, but those are inches that you're going to have to make up for, especially if you're at 12 o'clock trying to work on them. So have them scoot all the way up. Cushions really help. There are pediatric cushions, there's little booster cushions, there's knee cushions, because when you have a kid or even a petite adult scoot way up on the chair, the contour of the chair doesn't fit the contour of their body anymore, and they can be uncomfortable. So using these cushions, this is just the neck one, but using these cushions to plug in those open spaces, either behind their neck or in their low back or under their knees, really helps them be more comfortable. The booster cushions for kids are awesome because it supports them, but it also kind of locks them in place so that they're not squirming around moving in that chair. It kind of takes up some of that real estate so they can't be so squirmy. Then we have elderly patients. A lot of our elderly patients come in with this really pronounced forward head position, or they have kyphosis. Kyphosis is this excessive curvature of the upper spine. Some people also call it a hunchback. This can be difficult for them to get comfortable leaning back in the chair. It's not comfortable for them when they have a forward head position, they've got the hunchback, and we're trying to tip them back in the chair without supporting them with cushions or anything. It's not comfortable for them. It's like it's no wonder they don't want to be leaned back in the chair. And some of our elderly patients, besides that, they've got COPD or vertigo or like spinal fusions, and they cannot lean back in the chair. I do have some tips for you. I recommend standing whenever a patient cannot lean back in the chair, whether they're elderly or they're pregnant or maybe even a full-bodied patient. These can all be challenging for us to position them. I do recommend standing because that just gives you more play for yourself so that you have more room to work in those situations. Also, using a cushion. You could use a cushion like this for those elderly patients that have that severe forward head position. Using a cushion to help support their spine, you will be amazed at the difference it makes with positioning. You could use one like this. I even have an osteo cushion that is designed specifically for those patients with that severe forward head posture. I don't have it right now, but it's a much thicker cushion that kind of makes up for that forward head position and just keeps them a lot more comfortable. Now, with all this cushions and the headrest placements and all of that, I get asked often what my sequence is with patients, because when people are trying to learn how to use the cushions or adjusting the headrest or directing their patient, people are like, okay, well, how does that work when I'm working on both arches? You know, if you're a hygienist, you're working on the entire mouth. So are you adjusting your patient every time you go through with the hand scalers and the ultrasonic and the polishers, or like what? So let me just tell you what I do. This may or may not work for you, because everybody has their own system, but this is what works for me. I'll recline my patient typically between like semi-supine and supine, and I always polish first, always. By the way, I use a cordless polisher. If you haven't tried one yet or haven't used one, they are amazing. You don't realize how hard that cord is pulling on you till it's not there anymore. Anyway, love them. But I always polish first. Now, I don't usually adjust the headrest or the cushion between the arches when I'm polishing because it's so fast. I do ask the patient, please tip your chin way up so that I can do that for arch, and then I have them tip it down for the lower arch. But again, usually I'm done polishing within a few minutes, and it's not worth it for me to like go through adjusting the headrest or flipping the cushion around. After that, I usually do the lower arch first, and then I do the upper. I do the lower arch to completion. So I go through with the ultrasonic instrument, and then I go through with my hand instruments. And then that's when I position the patient correctly for the lower arch. I'm using the cushion, I'm adjusting the headrest, I do the lower arch. Then I reposition them, I flip the cushion around, I decline the headrest, I lean them back a little bit further for the maxillary arch. Then I go through with my ultrasonic instrument and my hand scalers for the upper. After that's done, I floss. I either floss sitting on my saddle stool or I'll stand up. I really like to incorporate standing as much as I can. Flossing is a great time to do this because a lot of times when we're flossing, we are out in chicken wing, but having the patient really low, which you can get when you're standing, helps kind of bring those arms in. So I'll go through and floss. Again, that's just my system. Everyone has their own system. That's just what works for me. I go over standing techniques and standing posture more in my operator positioning course, which I'll also link down below. I want to give you a couple tips, and these are kind of like tricky little tips for our patients, but they really help. One is the pre-recline. So let's say you've got Mrs. Jones out in the waiting room. You haven't even brought her back yet. You're going to pre-recline the chair just a little bit, like 10 or 20 degrees, just a little tip. So that when she comes and sits down and you're taking her blood pressure or doing the pre-rinse or just, chatting with her, she's already in a partially reclined position, which is getting her subconsciously used to not being fully upright. Then when you go to tip her back in the chair, it's not as far of a distance to go, and she's already kind of used to it, so it's not quite as disorienting for her. So that's tip number 1. Tip number 2 is what I call the slow lean back. This is something that I just started doing over time. I didn't even realize that I was doing it, but it really does help. When I seat my patient in the chair, I'm a hygienist, right? So I chat with them a little bit, but then I start grilling them on their hygiene. But I want to make sure it's a dialogue conversation to where I'm asking them a question and they need to answer me. So they're really focused on what my question is and they're thinking about what their answer is going to be. What they're not focused on is what I'm doing every time I ask a question, which is doing a tiny little tip back. Every question I ask, and I have a list of like 6 or 7 questions when I'm asking them about their hygiene, but every time I ask a question, I'm tipping them back a little bit. And I tip them again and tip them again. They're so focused on my conversation, they're not focused on what I'm doing, which is slowly tipping them back. And by the time I'm done asking all of my questions, they're all the way back into full supine and they haven't said a peep. That's something that can really help. Sometimes we just need to be a little tricky or distract our patients a little bit. You can use this for elderly patients or really for any of your patients. I know that we have patients that it's not that they can't lean back in the chair, it's that they just don't want to, right? And it is vulnerable. It's a very vulnerable, uncomfortable position to be leaned back in a chair, open your mouth, and let someone work on your teeth. It's not comfortable. I want to give you some tips on how to handle these patients. For patients who don't want to lean back, these cushions can be a lifesaver for you. These are huge, but you can also offer to compromise with your patient. We can treat the lower arch with them semi-reclined. They need to be in a semi-supine position, which is fine. So you can say, let's start with you partially reclined for the bottom teeth. That's fine, but I am going to need to recline you further for the upper teeth, but it will only take X minutes, like 5 or 10 minutes or whatever it is. When we have them start in that semi-supine position, they can get acclimated to that. They realize maybe it's not so bad. And then we tip them back just a few more inches for the upper arch. And that's a lot easier to tolerate than maybe us starting from them fully upright and going all the way back. So we can kind of baby step it with them a little bit. We can also offer to give them breaks. Be like, I do need to tip you all the way back for the upper arch. I'm happy to give you as many breaks as you need. Just let me know. And honestly, when patients lean back and they realize it's not that bad, they just want to get it over with. They're not really going to be asking you for breaks every 2 seconds. I think us being willing to compromise and give and take a little bit with our patients goes a long way with them. And just explaining to your patient that you need them to be reclined in a certain position for you to see their teeth. I'm working with sharp instruments. I want to do a good job for you. I have to be able to see your teeth. And to do that, I need you placed in this position. Just explaining why we're doing what we're doing and how it ultimately helps them also will help them be more compliant with us. I have had patients who have come in and said that they can't lean back in the chair. Maybe they kinked their neck the night before or their back or whatever. And they're like, I have to do this sitting upright. I got to the point with my body that I offered to reschedule them. I cannot work like that anymore because if I compromise my posture, I don't know if it's because I'm getting older or what, but if I compromise my posture that much with a patient, it affects me not just that day, but for days later, and it's not worth it to me. If we have patients with vertigo, this can be tough for them. And I have had vertigo, and I know what that feels like, and I don't want to make that any worse for anyone. Using something like this, a cushion to support their head and their neck, really helps, but also letting them control how quickly they lean back in the chair. So if you've got your patient just seated in the chair like normal, you can tell them, stay seated upright. I'm going to recline the back of the patient chair, and then you lower yourself as slowly or as quickly as you want to. That gives them control on how fast they want to lean back, and it just gives them a sense of control anyway, which really helps. If you need them to turn their head side to side, just ask them, I need you to turn your head to the right. Take as long as you need to. With vertigo, the slower and smaller movements typically work best. So that's a tip for vertigo. Now I want to show you the difference between regular loupes and ergonomic loupes when it comes to patient positioning. If you're listening to this podcast, I do recommend at least checking out this section on YouTube so you can see what I'm doing. I've got my old traditional loupes on, and I'm just going to demonstrate on this Pedo. But if I've got my patient up too high, I'm going to have to kind of really tuck my chin in order to see them. And if I'm working on them, I'm also going to be out here in chicken wing, or my elbows are not going to be bent at 90 degrees, which is going to be an awkward working position for me. So that's using regular loupes. Like, it's still going to be awkward. You're still going to be all crunched up here when your patient is positioned too high. Now I've got my ergonomic loupes. By the way, if you want to learn more about these ergonomic loupes, I have a whole podcast episode that I'll link down below. But let's say I've got my patient who can't lean back in the chair. Using ergonomic loupes, because of how they're designed, my head is actually going to be tipping up like this for me to see them, and I'm going to have to lean back like this. So whether or not you're using traditional or ergonomic loupes, if your patient is positioned too high, it's going to be an issue either way. It's just different kinds of awkwardness with your loupes. Most of us in dentistry are perfectionists. I mean, it makes us really good at what we do, but do not expect perfection all the time when it comes to posture and ergonomics. I know that's hard for a lot of us to wrap our heads around because we do want to be perfect all the time. It's not going to be that way. We're dealing with people. We're dealing with equipment. It's not going to be perfect all the time. I do recommend trying to be as perfect as you can with your ergonomics and posture, like 80% of the time. Most patients with the techniques I talked about here and the techniques I go over in my patient positioning course can get all the way down into the positions that we want. But if we've been as good as we can for about 80% of the time, and those patients come in that can't lean back or whatever, we have a little bit of gas left in the tank in order to treat them because we've been so good up until that point. But don't beat yourself up if it's not perfect, because it's not going to be all the time. I still see patients. I'm an ergonomic specialist, and it's not perfect for me all the time, and that's okay. We just want to do as best as we can. There is a lot to consider with patient positioning, and some of this does seem tedious, especially if you're not used to doing this already. Learning anything new is tedious. It's a pain, but then with repetition and practice, it becomes second nature, and then it'll come so naturally to you that you won't even have to think about it. Sometimes it's just easier not to position our patient right. Like, we just want to get through it and get it over with, but really it's not worth it over time, because these little small movements that we do as far as reaching and twisting and hunching and leaning, all of that adds up and could put us at risk for injury over time. Many injuries that dental professionals have, like low back injury or rotator cuff problems, carpal tunnel, is because of these small things that we're doing every day in the operatory repeatedly. And a lot of this comes back to how we position our patients. It is worth it to learn this and master this for yourself. Just think about how you want to feel, not just now, but like 20, 30, 40 years from now. Do you want to have a hunchback who has to go into the doctor all the time to manage your pain? Or do you want to have great posture, great energy, a great retirement, and good health? Everything we do now dictates how we're going to be decades in the future. I know for me, I want to be healthy for as long as possible. And so I'm trying to mitigate any risk factors now by learning things like this. If you're enjoying this content, please subscribe to my YouTube channel or follow my show wherever you listen to your podcast. Thank you for being here, and I'll talk to you soon.